Shrivastava, one of our professors of glaucoma, and he's also our director of residency education. And what we'd like for him to do is give you an update on some of our educational facility planning. So, Anurag.
Thank you very much. No, please no applause. Unnecessary. Sorry to sneak yet another lecture in on you. Is this really loud? Or is this me? Is it really loud? Can I turn that up? Sorry about that. Okay, so this is going to be pretty quick, because I know you guys are dying to get back to the lectures. This is going to be somewhat entertaining, hopefully, but it'll hopefully be more informative to what we plan on doing here at Montefiore for the residency. The title of this talk is Past, Present, and Future of Cataract Surgery, is really what we're talking about in ophthalmology. What we're going to talk about is going to work for many other types of surgery as well. So everyone here who's a doctor went to medical school, obviously, and we learned this certain thing that's been around for many, many years, from Norm Meadows' day, sorry Norm, to our current. What do we know? See one, do one, and teach one. Does anyone here have a story? I have about 1,000 of how this has gone completely awry. From the supposed champagne tap that became a Cabernet tap. The horrible things that happen to our patients because we don't institute the proper methods of teaching. So I want to get rid of this system, and I think we all do to some degree. The question is, what's the alternative? And that's really what we're here today to talk about. Can everyone hear me okay, by the way? Okay. So we do very delicate surgeries. Let's talk about cataracts for a moment. And we'll make an analogy, because we like food in ophthalmology. It's appropriate, it's lunchtime. Let's take an egg and call that the eye. And we'll say the yolk is the lens, and the albumin, the whites are the vitreous, and the kind of consistency-wise is pretty accurate. But as attendings, we do thousands of cases, and we learn how to do these things very adeptly, and we can do them in a matter of minutes, and it's really wonderful, the outcomes. So there's no sound to this, unfortunately, but I'll narrate very quickly what this French chef is doing when he's making an egg white omelet. He's got a nice accent, much better than mine. So he's taking us through the steps of removing the yolk from an egg. First step, we'll call this a clear cornea incision. Very gently opens it up. We'll call this the rhexis. And then takes out call it aqueous, although that's vitreous clearly. And then goes back and forth and separates the yolk expertly. No shell, nothing. This will make a really nice omelet, right? This is perfect technique. This is what we strive to do someday. And if you were listening to what he was saying, he's like, oh, if you drop a shell, get a spoon, also known as a retractor, and remove some of that. Well, we don't have that luxury in the eye. It's a very delicate organ, and the smallest micron mistake can lead to umarmian, getting a little extra work. So this is our omelet, day one. As attendings, we do these things all the time, and we get wonderful results, and we're so happy. The problem is, when we're the French chef, we train sous chefs. And what happens to the sous chef? In July, we get something like this sometimes, where there's corneal edema or an anterior chamber lens, for just the smallest little mistake. So the margin of errors on these things are very small. Of course, by June, we're back to this picture over here. But in July, this is how often things happen. So what do? We train residents with 86 cases to go from here to there, from the really bad-looking eye that we just don't like to see on day 1 or day 180, to the perfect eye, which has a perfectly well-centered lens, etc. So why 86 cases? Well, here's some data, because it's appropriate to bring some data into the argument. On the left-hand corner of this, you'll see the number of cases performed, and these are 9 residents in Colorado, average. This was in Journal of Cataract Refractive Surgery a couple of years ago. 0 to 25 cases, all the way to more than 100 cases. So how many cases do we do here? Well, we do between 86 and 100. Maybe a little more, maybe, hopefully not less. But we do somewhere in this ballpark here. And all the New York City programs are roughly the same. That's how many cataracts we learn how to do in New York City. Our program is no different. We start off the first couple, 25 cases, almost an hour. That's how long it takes. And then by the end of their training, we're down to half an hour. Respectively better. Certainly not what we are level at some of the ASCs here, but certainly you see a dramatic change over the course of this amount of training. Complication rate, even more interesting, 0.19, so 19% for the first 25%, which is a very, very high number, obviously. And greater than 100 down to 4%, which is still high, but within what you'd expect at that point of training. So we go a 5-fold increase in improvement over the course of 100 cases, the majority of which happens somewhere in here. So what can we do better? How can we improve those first 25? Get rid of that 20% complication rate almost. Here are the steps, and this is a lot of information, so I'll kind of just, the red things are the most important. If we assume that we want 95% of people to be proficient at cataract surgery in each step, when do they become proficient? Well, you see all the red 95s are higher for each of the steps. Some of these are interesting. Hydrodissection takes 100 cases. I don't believe that's true, but in this study it was. But the Rexas takes 76 to 100 cases for proficiency. Wound integrity, so you can make a wound to the top, but you can't have it not leak until later. Lots of interesting happens in this data. Well, the most important thing you have to think about here is nucleus disassembly and nucleus removal. You see, after 100 cases, 8% of people can't do that. And if you think of cataract extraction, that's the extraction part. So this is really critical. Leaving a lens in the eye obviously doesn't work. So even with a 92, or even with 100 cases, there's a certain amount of people that won't know how to do the surgery. So what are we doing? We're letting people slip through the cracks, frankly. And these are eyes that are treated and surgically operated on by our residents later in life. We have to do better to prevent, and this is nothing that anyone's done wrong, but it takes a long time to learn how to do this kind of surgery. So what's come out recently that can make us better? Now, a lot of you have seen this before. It's about 4 or 5 years old now. This is a new dry lab, wet lab system that allows for phaco training in a very safe and efficient manner. Let me hit this video. As the disco ball comes down. They're getting louder. So again, there's audio to this too. But you see in the upper left, the simulator. You see in the bottom right, a real surgery. The motions are identical, the instruments are identical, except this is done in a dry lab, or a wet lab if you will, without any vitreous loss, without any loss of vision, nothing. You see the step here, nucleus chopping, pre-chopping. You can do anything with this simulator, literally anything. Here's a phaco chop technique. So if you wanted to learn how to do a new technique, you didn't want to do it in a live eye, here's a wonderful way to do it in a safe environment. We have this available to us, but we don't have it here. Here's wound construction for the extra caps, for trabeculectomy. It's really for anything. It's artificial sclera. And you can see in the bottom right, things look exactly like they do in the real operating room. So that's remarkable. So what do our competition do? What do the other residencies in New York City do? Well, we know New York Eye and Ear put about that much money into this laboratory right here on the upper left. For over $1 million, they put 16 stations together. This is eye and ear, so the ENT people use it also. They have bone labs. But each laboratory station, and many of you have seen this, has a microscope, a setup, a foot pedal, so you can learn how to use all of these instruments. It's really a phenomenal place. They use the Kitaro system there for phaco training occasionally. And here you see some students actually working. They have their own instrument trays, et cetera, et cetera. So we need to do better for our residents, and that's what we're here to talk about today. This is what Wakefield used to look like, and this is the power of what Montefiore can do. If you look at this old, kind of raggedy looking hallway here, we've converted this in the last couple of years to something very respectable. It's bright, looks pretty, a place you'd want to go as a patient and as a doctor. The next slide, if you're squeamish, close your eyes, is what we have right now as our wet lab. It should be quiet because this is disturbing. We have a bunch of boxes, we have some microscopes in the corner. Here's our instrumentation on the bottom right, a bunch of instruments. And again, this is undoctored. Bob Tupper and I walked into this lab a few weeks ago and we're a little shocked to see this. But this is what we have right now. We have a beautiful operating microscope, but it's surrounded by a pneumotonometer, also known as a random number generator. Sorry, glaucoma joke. And then, all these instruments here. So what can we do to this to make it appropriate for our residents to learn how to do these very, very complicated cases? Well, here's what we've been working on. It's a slow fade because it's dramatic. So take a second to look at what we can do. This is the proposal I've put together with Bob Tupper from development, Lucy, where are you? Lucy, my architect. This is what we want to have. We want to have 6 stations, each one with its own microscope, state-of-the-art, video cameras, no assistant scopes, everything's on a video camera. You can stand behind and proctor a resident as they're doing the steps for each of the Katara WetLabs. We have a main screen on the top, which is connected to a video camera over here from a ceiling-mounted scope over an operating room bed. So now we can take patients, not really, it's a wet lab, but you can take artificial patients, learn how to put them into the proper positioning. There's a phaco machine back here. You can do a full phaco case on an artificial eye in a very, very safe environment. And this is all very possible. This has not been done for any residency in New York or the country. This will be the first multimedia lab of its kind. If we can do it, I think we can. Each one of these stations will also have something called Cataract Master. If you haven't heard of that, that is, and Anurag can agree, we looked at this together recently. It's something that Bonnie Henderson put together at NASA in here. And it's essentially an online simulator for cataract surgery. So for every step, they'll say, what do you do next? What would you do if you see this, etc. And it's a play-by-play for just cataracts alone. Each one of these stations will have this book. You can record your cases. You can do that capsulorhexis with a dry lab, record 1,000 of them, whatever you need to do. So the right tool for the job, that's what we're talking about here. We're up against this monster redwood and we have a little saw. And it's our job to train residents to conquer this level of a task. And we're coming up in July, this is when it happens. So the right tool for this job is very obvious. Here we have the French chef in the upper right-hand corner, and we have a very, very young resident who's learning how to do this very, very intricate task. And I have to thank Marlene Noster for this idea. What if we separate eggs like this? It's a neat little trick, but it just shows you the right tool for the right job can lead to fantastic outcomes. Our job is to give our residents the right tools. So what's the new mantra? See hundreds. We have iTube, YouTube, Cataract Master. We can do hundreds, and we can teach thousands, well before a patient ever hits the operating room, if they don't get canceled first. We're dedicating this lab to our former chairman, Ronald M. Burde, and Jeff Schultz, and Roy Chuck, and all of us have been very active, including the development office, contacted the Burde family. They're extremely excited about this. This is another view of the lab from another view, looking at the scope and the surgical chair here. They have donated money already. The Chuck family has matched it. Norm Meadow last night also has donated as well. We're hoping everyone can help us here. The price tag on this, the New York Idea one was $1.2 million. We can do it for about 25% of the cost. Not cheap, but relative to what we're up against, it's not a lot of money. We can do this. So I'm going to turn the mic over to Jeff Schultz. Sorry, it was back in the back of the room here. Who's going to tell you a little bit more about the Burde family and potentially what we're going to ask as we go down the line here.
Thank you. Okay. And I'm totally unprepared to give this talk. I just want to say something kind of really briefly. I've been in. When we look at what today is, okay, and we look at some of the names who are associated with this meeting: George Wise, Paul Henkind, Ron Burde. You know, what's the final common pathway between them? Well, one is excellence. These are people who cared about being the best at what they do. And second is teaching. Because what we do for ourselves is meaningful, and for our patients that we take care of, but the more people we train, the better those people are, the public is so much better off. So this is such a critical issue. Ron was and is a terrific person, and I've been in touch with Sharon, and we've discussed a lot of things. And what I really want to do, and this is I think Sharon was very concerned about me speaking extemporaneously, so she kind of we came up with this little script for me to describe the onset of what we're doing. We're trying to create is the Ronald M. Burde Fund for Resident Education. Okay? And it's scripted as such that Ronald M. Burde served as chairman of the Department of Ophthalmology at Montefiore Hospital, Albert Einstein College of Medicine from July 1st, 1988 to September 1st, 2000. During his tenure, the department was widely recognized for excellence in teaching, research, clinical practice, as well as innovation and community involvement. Ron remains dedicated to these goals as his successor, Dr. Roy Chuck. The establishment of the Ronald M. Burde MD Fund for Resident Education will assure the state-of-the-art training in residency education. The Anurag's done a spectacular job kind of bringing you to front, what would be the initial project for this fund. But this is something hopefully that will continue and be ongoing in order to create, not just good residents, the best residents. Isn't that something to look forward? And again, I'm really delighted that, Sharon, really jumped on board of this and supporting it with Ron and Norm Meadow. It's really terrific. And it's my sincerest hope that we as a family in the Department of Ophthalmology, in some respect, that's what Ron was about. Ron was about, when he was here, creating a family in the department. This is a family. Try to keep this noble and important resource vital. So, while we're seeing you today, you may be seeing us a lot more, or hearing for us a lot more in the future. So expect it. Thank you.
Thank you very much. So I really have no closing statement other than I think the picture speaks for itself. This is what we need, and we need everyone's help. This is a really important thing, not only for the department, but for the future of ophthalmology. So I thank you for your attention, and sorry for the surprise lecture during your lunch. But I hope that you at least have a sense of where we're going with this, and that you'll be willing to help pitch it in any way, shape, or form you can. The other thing I'd quickly mention, which I did mention earlier, for the faculty, volunteer attendings in the community, if you haven't done certain types of surgery, let's say you've never put an Ahmed segment in, or you've never done a a scleral fixated lens, the new Kitaro complex kit actually allows you to learn how to do that stuff. This is 24/7, this lab is open. So if you ever have a question, I got a case coming up, I'm going to put this to the sclera, I've never done that. You can actually do that on an eye before you go into the operating room. Ahmed segments, similarly, iris hooks if you haven't done that. It's almost impossible to do, but if you never saw that for some reason. Capsular tension hooks, any kind you want, any new instrument you want to use, you can come into this lab whenever you need to. It's your resource as well. And try whatever you want. You can tape your own cases. You can look at iTube or YouTube, see how it's done, and then mimic it at the same moment. So I will leave it at that. So there's really a lot in here for everybody, if we choose to do it. And I think it's not really a choice anymore. This is something we have to do. The question is when and how. I thank you again for your time.